morning. I hope you can understand and see me on your screen now. Good morning. Okay, excellent. So the topic of this morning session is aortoiliac disease, and we have heard a lot of talks about the linkage of peripheral artery disease and coronary disease and other concomitant diseases, and I thought it may be of interest to show a case which is not a typical aortoiliac case, but it's linked to aortic disease. Today we are treating a patient with mesenteric artery disease, with symptomatic disease, and I will guide you briefly through this case. Next slide, please. These are my disclosures. I have nothing to disclose related to this particular case I will show you this morning. Next slide, please. So this is an 83-year-old male patient who developed progressive abdominal angina starting about 15 to 30 minutes after meals. The interesting aspect of his history is basically that a couple of weeks he developed this pain, and a couple of minutes after starting or onset of this abdominal pain, he suffered a syncope. And he was admitted to the university hospital very close by in Freiburg, and they diagnosed an AV block, and so he did receive a pacemaker. But a couple of weeks later, he developed the same symptoms, abdominal pain after ingestion, and a syncope again despite the pacemaker. And this made then the home care physician aware of there may be something else underlying than heart rhythm problems. So he underwent a CT scan, and there the diagnosis of mesenteric artery disease was made, suggesting subtotal occlusions of the superior mesenteric artery and the celiac trunk, and an occlusion of the inferior mesenteric artery. So the patient has the typical risk factors. Next slide, please. I don't have the CT images available because the CT was done in another hospital. Next slide, please. So this is the intended strategy. I created a retrograde femoral access via the right groin, 6 French short sheaths, and short 55 centimeter long IMA guiding catheter is in place, and I intended to implant stents. Usually I'm using the biggest available dedicated renal stent, so pre-mounted renal low-profile stents with the biggest dimension is 7 millimeter. In this particular case, for the SMA, I will use a little bit smaller stent. So I will briefly guide you through the angiogram because before we can discuss the case. If we can get this is just a still image. That's a very right oblique image. It's 60 degrees, and you can see the aorta, which is really diffusely diseased, and you can see some focal high density calcium areas over here and here. The upper one is representing the celiac trunk origin. The middle is the SMA, and this is the left renal artery. So it's no doubt that this is a real aortic disease, which is extending into the origin typically of the side branches. So besides the heart problem with the pacemaker in place, the patient already underwent a couple of peripheral interventions. Years ago in another institution, you can see here a stent placed in the right common iliac artery in a technique I don't like so much because the stent is covering also the origin of the left common iliac artery. Now this is a non-selective angiogram, so we can't see a lot. And this is now the IMA catheter orientated towards the SMA, and you can nicely see here that this is really, a subtotal occlusion. So it's a minor channel which is still existing. In addition, you may appreciate at the distal end of the initial curve there is some haziness, there is some competitive flow. So the contrast medium is diluted over there. This is a collateral filling, most likely coming from the celiac trunk or even coming from the internal iliac arteries. So any comments or questions regarding the case so far?
Professor Zeller, do you normally approach your mesenteric vessels from the femoral approach, or do you sometimes utilize a brachial approach for treatment?
It depends on the pre-interventional CT or MR imaging findings. In particular, the SMA sometimes is showing a very acute, steep caudal angle at the origin. If this is present, a brachial access is my preferred access. But here, I was aware that it's a more or less horizontal takeoff of the superior mesenteric artery, and this made me to decide to use the femoral access because it's a shorter access as coming from the arm. The catheter position is more stable as compared to a brachial access. And usually also the celiac trunk has a more horizontal offtake. So it should be possible to also reach to this artery from the femoral access. But you are right, it really depends on the pre-interventional imaging workup, which kind of access you are intending to use, whether it's an antegrade, transbrachial, left transbrachial, or a femoral approach.
Any other comments from the panel?
Since you said that you are at 60 degrees RAO, I had a question. Do you ever rely on 3D fusion based on preoperative CT scans? Here you have a short stump to aim at, but frequently you will see pretty flush occlusions. So have you ever tried using 3D fusion to find the proximal celiac and SMA stumps?
No, I didn't use it yet. We have these imaging options available, not in this lab, but in our OR lab. It would be possible. What I'm sometimes doing alternatively is that if the IMA or the celiac trunk is patent, that I use this for injecting contrast medium to identify the occlusion side of the SMA, for example. This morning I had a very similar case, morning our local time. So, but I didn't yet use the fusion imaging options.
What does the panel think about?
Well, to proceed.
I just wanted to ask the panel a quick question about stenting strategy here.
Go ahead.
Would anybody on the panel consider covered stenting for this type of lesion?
I think a covered stent may be a reasonable option here as well. One advantage is covering some of the concomitant calcific disease that typically we see at the aortic ostium. The one downside is you likely have to use a larger French sheath size, though, as well.
Yeah, well, that's a very, very good discussion point. There is one major indication, in my opinion, for using a covered stent if it would be available. This is the relatively high restenosis rate of such interventions. I don't know why, but it's typically reported, and it's not only our own experience, that the restenosis rate of visceral interventions, in particular mesenteric interventions, is in a range of 30%, whereas the restenosis rate for renal stenting is about 10 or even lower percent. And we are dealing with the same stent dimensions in those arteries, and for me it's uncertain why we are experiencing these differences in restenosis rate. And if I would have covered stent, which is coming in a monorail version like this stent here, I would clearly prefer the use of a covered stent in this indication. A couple of years ago, there was the Advanta stent available, or in the US it's branded as iCast. It was available also for renal application, but it's not anymore available, unfortunately. So basically what I do have in place here, this is a 6.5 millimeter stent in diameter, and it's 15 millimeter in length. Name is hippocampus. This is a very special stent device because the delivery balloon has a very long nose cone, so the distal tip is extended. This enables you and facilitates the introduction of the system into either renal arteries or mesenteric arteries. So I'm checking now the position. I'm a little bit deep inside the artery, so I'm trying to pull back the stent a few millimeters that I really cover the origin. So
This is a case also where you have plenty of dystrophic calcium to help guide you.
exactly. So the identification of the offtake of the artery is not that difficult. The challenge is more to get across subtotal occlusions, and you need to predilate. There's so much friction. So there is no way for direct stenting, what I prefer for renals, to be honest. So
That dilated
predilatation
really
was
well.
done with a 3.5 millimeter balloon, and it's, yeah, there's a small waste, which is not significant. So one discussion point is, would you go now directly for the second artery, meaning for the celiac trunk, if diseased, or would you stay with the SMA and watch and wait what the clinical symptoms look like after this treatment? What's the panel's opinion?
I usually just do one. I start with the SMA, and then I see how the patient responds.
I may do both, depending upon how critical the other lesion appears.
Yeah. Okay. So let's just check the result here of the SMA, and then we can have a look on the celiac trunk. Mal bitte nicht atmen, ganz ruhig liegen.
It's very nice.
There's a mismatch. Yeah, at the origin it looks good. And there's a mismatch distal to the stent. Would you leave it, or would you extend here for another stent?
This is one situation where actually IVUS might be of benefit, but maybe take another view and reevaluate.
Ja.
Anybody on the panel with stent?
Nochmal kurz nicht atmen.
I think IVUS is probably a good option. Just
Okay.
to see to extend it.
I would probably extend.
So this is now a selective shot. There is still a small waste, but I would say there is no dissection.
Yeah, I don't see a
It's,
dissection.
It's a moderate lesion. Yeah, exactly. So it's a moderate lesion. So I personally tend to leave it without a stent. The reason for that is we are located in this curve, and when extending here with another stent, it would need a self-expanding stent. I wouldn't implant here a balloon expandable stent into this curve. So my intention is here to leave it and wait what happens. Okay. So I'm trying now to navigate the catheter upstream towards the most likely location of the celiac trunk origin. How much transmission time do I still have?
We have 5 minutes.
Oops. Okay. Let's see. It looks as being occluded.
Yeah, that. Looking at that,
At least
I
in
would
this,
probably
in
leave
this
it.
view.
At that point.
Yeah. Yeah. Bitte nochmal nicht atmen, nicht bewegen. No. There is no flow.
Can we see if the SMA
So that
provides
means now we have a
collaterals?
single. Yeah, I will show you. So, bitte nochmal ganz kurz den Atem anhalten. Ja,
Yeah, I think that's a clear indication to probably stop.
yeah. Yeah, we have a nice retrograde filling here of the splenic artery and the hepatic artery, so this is obvious that this is an occlusion. We have a very big diameter of the SMA, and I would stop here. Now we have a good one vessel perfusion of the abdomen, and this should be enough. Everybody in agreement?
Everybody, I think, agrees with that assessment. This was a great case in a very hostile aortic environment that you have to deal with. And I think this was a phenomenal job that you did today. And we always appreciate seeing you at NCVH and watching you do your live cases on a year-to-year basis. Thank you, Dr. Zeller.